Hello, my name's Ryan. Today we're going to be doing a cardiovascular examination on you. Can I just get you to confirm your name and date of birth, please?
Yep, Ashley Gaffney, 6th of August 1992.
Cool. Right, so the aim of this procedure is to identify any possible cardiac complications that you might have. What it involves is palpation, auscultation and a general inspection of you. Are you okay with that?
Yep, that's fine.
Cool. We want to look at the patient's environment. This includes whether they've got medications around them, such as GTN, aspirin, whether they're on, if there are any O2 bottles around, also looking for cigarette packets and smells, things like that. We're also going to be assessing whether the patient's comfortable at rest at the moment. So the first thing you do is ask them, so Ashley, are you in any pain at the moment?
No.
No? And as you can see, there's no shortness of breath and she doesn't appear to be in any pain. We're also going to be assessing how they look in terms of colour. So Ashley's got a nice pinkish tone, which is what we want to see. Any cyanosis around the lips or the peripherals may indicate a lack of oxygenated blood flow. We're going to commence the examination with an inspection of the patient's hands. So I'm just going to start by doing a radial pulse check. So Ashley, is that okay with you?
Yep.
So we're just checking the patient's radial pulse. We're looking for strength, regularity and rate. So that's in a normal range. We're now going to do what's called a radial pulse, which is both of them at the same time. So we're looking to feel whether there's any delay between the two. If there was, that would indicate that the patient may have aortic coarctation. Any irregularity found, depending on the patient's condition in their pulse or circulation, would be hospitalisation or further medical assistance if not so urgent. Ashley, I'm now going to ask you to put your hands outwards with your palms facing down. So what we're going to be doing is looking for reddish brown streaks on the nail bed. This could indicate splinter hemorrhages, and they occur from bacterial endocarditis. We also, are you able to just put your hands up like this for me?
Yep.
And if there's no gap visible between there, that could indicate the patient has finger clubbing, and that's a sign of infective endocarditis, or also cyanotic congenital heart disease. Right, so Ashley, I'm just going to get you to put your hands out with your palms facing upwards. So what we're assessing now is how her hands look, whether there's any discoloration, so grey or blue, may indicate cyanosis due to hypoxia. No problems here. We're also going to be feeling the patient's hands to feel the temperature. So if it was cold, this could be due to a poor cardiac output, such as hypovolemia. No worries here. We're also going to be assessing if they were warm or clammy. That might indicate acute coronary syndrome. We're also going to be checking the capillary refill on both sides. So we're seeing how fast. If it's less than 2 seconds, then that's normal. If it's longer, this could be due to hypovolemia once again. Many other things to look for, such as tar, cigarette smoking, all have vast impacts on the cardiovascular system. In the appropriate environment, a blood pressure would be taken. This is useful for spotting abnormalities in the systolic or diastolic pressures. Good for determining extreme levels of hyper or hypotension. If extreme, there can often be underlying cardiac issues such as bradycardia, heart valve problems, heart attacks, heart failure, ruptured aortas. They all contribute towards hypo or hypertension. As I said, in extreme levels, often these patients would be deemed status 1 or 2 and require immediate hospitalisation. We're going to move on to the neck, head and facial region. So first we're going to start off with a pulse check. So this involves taking a pulse on both sides of the neck. They're called carotid pulses. So Ashley, I'm just going to take your pulse.
Yep.
Thank you. Cool. So what we're doing now is we're feeling for strength, regularity and the rate. We're feeling if it's the same on both sides. And what we're going to do now is I'm just going to ask Ashley if you could look over towards the wall. Tilt your head back a little bit, just like that. So what we're doing now is we're looking for jugular venous pressure. We're now going to move on and conduct a couple of eye and mouth examinations on the patient. So the first thing I'll get you to do, Ashley, is if you could pull down your eyelid. So we're just looking for conjunctival pallor. This could indicate that the patient has anemia. We're now going to be inspecting the patient's mouth. So we're looking for colour, looking to see if there's any blue tinge around it. Not present today. Ashley, would you just be able to open your mouth for me and then raise your tongue to the roof of your mouth? Thank you. So now we're just going to do a chest inspection. So this involves identifying any scars. We're looking for thoracotomy scars, which involves an incision into the pleural space of the chest. We're looking to see whether the patient has had a sternotomy. This is practically just any heart surgery, so history of heart disease, grafting, or valve surgeries. We're looking for clavicular scars, indicating the patient might have a pacemaker. Very important to identify any of these for your treatment plan, and identifying pacemakers, very beneficial for interpretation of a 12 lead. Now we're going to begin palpation of the patient's chest. It's very important just to explain the procedure and gain consent because it is quite an invasive process. So, Ashley, do you mind if I palpate your chest?
No, that's fine.
Okay, so we're finding the middle on the sternum, going down 5 intercostal spaces, and then mid-clavicular, and just palpating to feel the apex beat. So now we're going to begin auscultation of the chest. So stethoscopes are usually a bit cold, so just give it a bit of a warm-up. Important to warn the patient, it's going to be a bit cold.
Okay.
Explain the procedure again and gain consent. So actually what we're going to do is I'm just going to listen to your 4 valves of your heart.
Yeah.
Is that okay?
Yeah.
Cool. Right. So we're going to start with palpating the carotid pulse with your free hand, and I'm just going to go through the aortic, pulmonary, tricuspid, and mitral valves.
Auscultation of the heart valves can help gather information about the rate and rhythm, valve functioning, and anatomical defects of the heart. Heart sounds are the noises generated by the beating heart and the resultant flow of blood through it. Specifically, the sounds reflect the turbulence created when the heart valve snaps shut. The snapping shut of the atrioventricular valves and semilunar valves create the first and second heart sounds, S1 and S2. Additionally, murmurs, adventitious sounds, and gallop rhythms may be audible in heart sounds 3 and 4.
We're now going to do some accentuation maneuvers. These cause certain murmurs to become louder during expiration. So, Ashley, if you could just lie down on your left-hand side.
Yeah.
What we're going to do is we're going to locate the mitral valve again, and we're using the bell end of the stethoscope. Are you comfy there?
Yep.
Okay. So when I say, if you can just breathe in and out nice and deeply. So. Alright, just in and out, please. Ashley, could you just lean forward a little bit? And when I ask if you could breathe in and out for me. Right, just in and out. Thank you. We're now just going to auscultate the bases of the lung. So, Ashley, would you mind just rotating to your right?
Sure.
Thank you. So, we're listening out for anything abnormal, of course, but anything in particular for cardiovascular system would be crackles. So just a deep breath in and out. Thank you. While we've got the patient in this position, it would be a good time to palpate for sacral edema. It's also good to see if there's any posture differences, if there's any colour that's different to the chest. And we can also percuss to rule out right ventricular failure in pleural effusion. I'm just going to do a quick abdominal and legs assessment of the patient. So Ashley, would you be able to lie down with your legs facing this way? So we're just going to inspect the patient's abdomen for abdominal distension. This could be due to ascites, which is extra fluid in the peritoneal space. Nothing wrong there. We're going to move down to the legs. We're inspecting the legs for harvesting sites, cyanosis, missing limbs or toes, and we're also going to palpate around the ankle area for pitting edema as a result of congestive heart failure. This is concluding the end of our cardiovascular examination. So first of all, I'd like to say thank you, Ashley, for being a good patient.
That's all right.
And you can just have some Eskimos for being
you.
so good. Ashley here would have been a status 4 because there were no abnormal findings. Status 1s and 2s, however, require immediate hospital transport. Whether it's status 1 or 2 is determinant on the level of cardiac compromise, whether it's an immediate threat to life or a potential threat to life. When transporting the patient, obviously we're going to monitor them the whole time. We're going to put on a 12-lead ECG and we're going to reassess their vitals constantly. Gathering a patient history, as we've seen glimpses throughout this video, can help to determine whether what we're finding is normal for the patient. It may be normal because of their previous cardiac problems, so this could be operations, surgeries, anything like scars, medications, just help piece together the puzzle. If it's not normal, obviously transport. Status 3 and 4 patients, hospital admission is not always required. However, we can refer them to a specialist, see their GP, if anything that's slightly abnormal but non-life-threatening is found. To do a more comprehensive examination on Ashley here, we could have used a 12-lead ECG to find arrhythmias or MIs. We could have done a peripheral vascular examination, taken a dipstick urine test, and a BGL reading. So, thank you for watching my OSCE.